Behavioral Health Services. Appendix PP, Regulation Section 483.40, tags F740 through F745. Begin reading. Tag F741. Section 483.40, 0A, the facility must have sufficient staff who provide direct services to residents with the appropriate competencies and skills sets to provide nursing and related services to assure resident safety and attain or maintain the highest practicable physical, mental, and psychosocial well-being of each resident, as determined by resident assessments and individual plans of care, and considering the number, acuity, and diagnosis of the facility's resident population in accordance with Section 483.71. These competencies and skills sets include, but are not limited to, knowledge of and appropriate training and supervision for Section 483.40A1, caring for residents with mental and psychosocial disorders, as well as residents with a history of trauma and or post-traumatic stress disorder that have been identified in the facility assessment conducted pursuant to Section 483.71 and Section 483.40A2, implementing non-pharmacological interventions. Intent Section 483.40A, A1 and A2. The intent of this requirement is to ensure that the facility has sufficient staff members who possess the basic competencies and skills sets to meet the behavioral health needs of residents for whom the facility has assessed and developed care plans. The facility must consider the acuity of the population and its assessment in accordance with Section 483.71. This includes residents with mental disorders, psychosocial disorders, or substance use disorders (SUDS), and those with a history of trauma and or post-traumatic stress disorder (PTSD), as reflected in the facility assessment. Facility staff members must implement person-centered care approaches designed to meet the individual goals and needs of each resident. Additionally, for residents with behavioral health needs, non-pharmacological interventions must be developed and implemented. Note: for sufficient staffing concerns that fall outside the scope of behavioral health care, review regulatory requirements at Section 483.3, 5A F725, sufficient nursing staff, and Section 483.3, 5A3 F726, competent nursing staff. Definitions Section 483.40A, A1 and A2. Definitions are provided to clarify terminology related to behavioral health services and the attainment or maintenance of a resident's highest practicable well-being. Mental disorder is a syndrome characterized by a clinically significant disturbance in an individual's cognition, emotion regulation, or behavior that reflects a dysfunction in the psychological, biological, or developmental processes underlying mental functioning. Mental disorders are usually associated with significant distress or disability in social, occupational, or other important activities. American Psychiatric Association, Diagnostic and Statistical Manual of Mental Disorders, 5th edition, 2013. Substance use disorder, SUD, is defined as recurrent use of alcohol and or drugs that causes clinically and functionally significant impairment, such as health problems, disability, and failure to meet major responsibilities at work, school, or home. Adapted from Substance Abuse and Mental Health Services Administration, SAMHSA. Mental Health and Substance Use Disorders. Accessed March 2, 2021. https://www.samhsa.gov/findhelp/disorders. Trauma results from an event, series of events, or set of circumstances that is experienced by an individual as physically or emotionally harmful or life-threatening. And that has lasting adverse effects on the individual's functioning and mental, physical, social, emotional, or spiritual well-being. SAMHSA concept of trauma and guidance for a trauma-informed approach, July 2014, accessed February 25, 2021. https://ncsaquasamsagov/user-files/samhsa trauma PDF. Post-traumatic stress disorder occurs in some individuals who have encountered a shocking, scary, or dangerous situation. Symptoms usually begin early, within 3 months of the traumatic incident, but sometimes they begin years afterward. Symptoms must last more than a month and be severe enough to interfere with relationships or work to be considered PTSD. National Institute of Mental Health, Post-Traumatic Stress Disorder, accessed November 9, 2022, https://www.nimnigov/health/topics/post-traumatic stress disorder PTSD. This brochure describes symptoms, causes, and treatments for post-traumatic stress disorder, with information on ways to get help and cope effectively. Non-pharmacological intervention refers to approaches to care that do not involve medications, generally directed towards stabilizing and or improving a resident's mental, physical, and psychosocial well-being. Guidance Section 483.40a, A1 and A2. Sufficient staff to provide behavioral health care and services. The facility must address in its facility assessment under Section 483.71f, 838, the behavioral health needs that can be met, and the numbers and types of staff needed to meet these needs. If a resident qualifies for specialized level Roman II services under PASAR, please refer to Section 483.20 KF 645. If the resident does not qualify for specialized services under PASAR but requires more intensive behavioral health services, e.g., individual counseling, the facility must demonstrate reasonable attempts to provide for or arrange for such services. This would include ensuring that the types of services needed is clearly identified based on the individual assessment, care plan, and strategies to arrange such services. Facilities must have sufficient direct care staff, nurse aides, and licensed nurses with knowledge of behavioral health care and services in accordance with the care plans for all residents, including those with mental or psychosocial disorders, SUDS, as well as residents with a history of trauma and or PTSD. Facilities may be concerned about accessing sufficient professional behavioral health resources, e.g., psychiatrists, to meet these requirements due to shortages in behavioral and mental health providers in their area. A facility will not be cited for non-compliance if there are demonstrated attempts to access such services. Facilities are not expected to provide services that are not covered by Medicare, Medicaid. They are expected to take reasonable steps to seek alternative sources, state, county, or local programs, but if they are not successful, it is not the basis for a deficient practice, skill, and competency of staff. The facility must identify the skills and competencies needed by staff to work effectively with residents both with and without mental disorders, psychosocial disorders, SUDS, a history of trauma, and or PTSD. Staff need to be knowledgeable about implementing non-pharmacological interventions, the skills and competencies needed to care for residents should be identified through the facility assessment. The facility assessment must include an evaluation of the overall number of facility staff needed to ensure that a sufficient number of qualified staff are available to meet each resident's needs. Furthermore, The assessment should include a competency-based approach to determine the knowledge and skills required among staff to ensure residents are able to maintain or attain their highest practicable physical, functional, mental, and psychosocial well-being, and meet current professional standards of practice. This also includes any ethnic, cultural, or religious factors that may need to be considered to meet resident needs, such as activities, food preferences, and any other aspect of care identified. Once the necessary skills and competencies are identified, staff must be aware of those disease processes and disorders, e.g., SUDs, that are relevant to each resident to enhance the resident's psychological and emotional well-being. Competency is established by observing the staff's ability to use this knowledge through the demonstration of skill and the implementation of specific, person-centered interventions identified in the care plan to meet residents' behavioral health care needs. Additionally, competency involves staff's ability to communicate and interact with residents in a way that promotes psychosocial and emotional well-being, as well as meaningful engagements. Under Section 483.15(2), requirements for approval of a nurse aide training and competency evaluation program, nurse aides are required to complete and provide documentation of training that includes, but is not limited to, competencies in areas such as communication and interpersonal skills, promoting residents' independence, respecting residents' rights, caring for the residents' environment, mental health and social service needs, and care of cognitively impaired residents. All staff must have knowledge and skills sets to effectively interact with residents. Communication, resident rights, meaningful activities, person-centered approaches to care should be implemented based upon the comprehensive assessment in accordance with the resident's customary daily routine, lifelong patterns, interests, preferences, and choices, and should involve the interdisciplinary team IT, the resident, residents, family, and or representative S. The IDT should be aware of potential underlying causes and or triggers that may lead to expressions or indications of distress and or traumatization, identifying the frequency, intensity, duration, and impact of a resident's expressions or indications of distress, as well as the location, surroundings, or situation in which they occur, may help the IDT identify individualized interventions or approaches to care to support the resident's goals and needs. Individualized, person-centered approaches to care must be implemented to address expressions or indications of distress. Staff must also monitor the effectiveness of the interventions, changing those approaches, if needed, in accordance with current standards of practice. Additionally, they must accurately document these actions in the resident's medical record and provide ongoing assessment as to whether they are improving or stabilizing the resident's status or causing adverse consequences. The following discussion of non-pharmacological interventions supports all residents. However, residents living with behavioral health needs may require a more formalized, documented intervention plan. Non-pharmacological interventions. Examples of individualized, non-pharmacological interventions to help meet behavioral health needs of all ages may include, but are not limited to, ensuring adequate hydration and nutrition, e.g., enhancing taste and presentation of food, addressing food preferences to improve appetite and reduce the need for medications intended to stimulate appetite, exercise, and pain relief, individualizing sleep and dining routines, as well as schedules to use the bathroom to reduce the occurrence of incontinence, taking into consideration the potential need for increased dietary fiber to prevent or reduce constipation, and avoiding, where clinically inappropriate, the use of medications that may have significant adverse consequences, e.g., laxatives and stool softeners. Adjusting the environment to be more individually preferred and home-like, e.g., using soft lighting to avoid glare, providing areas that stimulate interest or allow safe, unobstructed walking, eliminating loud noises, thereby reducing unnecessary auditory environment stimulation. Assigning staff to optimize familiarity and consistency with the resident and their needs, e.g., consistent caregiver assignment. Supporting the resident through meaningful activities that match his or her individual abilities, e.g., simplifying or segmenting tasks for a resident who has trouble following complex directions, interests, goals, and needs based upon the comprehensive assessment, and that may be reminiscent of lifelong work or activity patterns, e.g., providing an early morning activity for a farmer used to waking up early. Assisting the resident outdoors in the sunshine and fresh air, e.g., in a non-smoking area for a non-smoking resident. Providing access to pets or animals for the resident who enjoys pets, e.g., a cat for a resident who used to have a cat of their own. Assisting the resident to participate in activities that support their spiritual needs. Assisting with the opportunity for meditation and associated physical activity, e.g., chair yoga. Focusing the resident on activities that decrease stress and increase awareness of actual surroundings, such as familiar activities, offering verbal reassurance, especially in terms of keeping the resident safe and acknowledging that the resident's experience is real to her/him. Utilizing techniques such as music, art, electronic/computer technology systems. Massage, essential oils, reminiscing. Assisting residents with SUDS to access counseling, e.g., individual or group counseling services, 12-step programs, and support groups to the fullest degree possible. Assisting residents with access to therapies, such as psychotherapy, behavior modification, cognitive behavioral therapy, and problem-solving therapy, and providing support with skills related to verbal de-escalation, coping skills, and stress management. For additional guidance and examples of individualized non-pharmacological interventions, see Section 483.2, 4 CF 679, Activities. While there may be situations where a pharmacological intervention is indicated first, these situations do not negate the obligation of the facility to also develop and implement appropriate non-pharmacological interventions. Note, this guidance is not intended to exclude the use of pharmacological interventions when they are clinically necessary and appropriate. Please see the Pharmacy Services section under Section 483.4, 5DF 757, Unnecessary Drugs, and Section 483.4, 5EF 758, Psychotropic Drugs, for additional guidance. Investigative Protocol Section 483.40A, A1 and A2. Determination of sufficient staffing. One factor used to determine sufficiency of staff, including both quantity and competency of staff, is the facility's ability to provide needed care for residents as determined by resident assessments and individual care plans. A staffing deficiency must be supported by examples of care deficits caused by insufficient quantity or competency of staff. The surveyor's investigation will include whether inadequate quantity or competency of staff prevented residents from reaching the highest practicable level of well-being. A deficiency of insufficient staffing is determined through observations, interviews, and or record reviews. Information gathered through these sources will help the surveyor in determining non-compliance. Concerns such as expressions or indications of distress by residents or family members, residents living with mental, psychosocial, and or SUDS, as well as residents with a history of trauma and or PTSD who lack care plan. Interventions to address their individual goals, needs, lack of resident engagement, and the incidence of elopement and resident altercations can also offer insight into the sufficiency and competency of staff and the adequacy of training provided to them to care for residents with behavioral health needs. Determination of staff competencies. As required under Section 483.71 F. 838, the facility's assessment must include an evaluation of staff competencies that are necessary to provide the level and types of care needed for the resident population. The facility must have a process for evaluating these competencies. If sufficient and or competent staffing concerns are present during the surveyor's investigation or while completing the sufficient and competent staffing facility task, refer to the Behavioral and Emotional Status, CMS, 20067 Critical Element Pathway. Key Elements of Noncompliance Section 483.40A, A1 and A2. To cite deficient practice at F741, the surveyor's investigation will generally show that the facility failed to rule out underlying causes for the resident's behavioral health care needs through assessment, diagnosis, and treatment by qualified professionals, such as physicians, including psychiatrists or neurologists. Identify competencies and skills sets needed in the facility to work effectively with residents with mental disorders and other behavioral health needs. Identify the signs and symptoms of substance use in a resident with SUD. Provide care in accordance with the individualized care plan that meets the needs of residents with mental disorders, substance use disorders, a history of past trauma, and other behavioral health needs. Provide sufficient staff who have the knowledge, training, competencies, and skills sets to address behavioral health care needs. Demonstrate reasonable attempts to secure professional behavioral health services when needed. Utilize and implement non-pharmacological approaches to care based upon the comprehensive assessment and plan of care and in accordance with the resident's abilities, customary daily routine, lifelong patterns, interests, preferences, and choices. Monitor and provide ongoing assessment of the resident's behavioral health needs as to whether the interventions are improving or stabilizing the resident's status or causing adverse consequences, or attempt alternate approaches to care for the resident's assessed behavioral health needs if necessary. Note, in the case of a negative resident outcome, the surveyor must investigate whether or not the facility considered all relevant factors that may have contributed to the outcome. Doing so, while also using the points described in the key elements, will assist the survey team in determining if an identified concern was avoidable or unavoidable. Deficiency Categorization Section 483.40A, A1 and A2. An example of Severity Level 4 noncompliance. Immediate jeopardy to resident health or safety includes, but is not limited to, the care plan of a resident diagnosed with depression and suicidal ideation. Included close supervision and one-on-one activities with staff. Based upon documentation in the resident's record, the resident was often isolated in her room and increasingly spoke of wanting to die. Additionally, the resident had recently been transported to an acute care facility for a psychiatric evaluation when she threatened to harm herself and was deemed inconsolable by facility staff. During an interview, the director of nursing Dawn indicated that on many evening and weekend shifts the facility did not have enough staff to provide close supervision. or one-on-one activities for the resident. No other alternative arrangements had been developed, care planned, or implemented to ensure the resident's behavioral health needs were met. The facility lacked sufficient staff with the required skills sets to implement the resident's care planned interventions. This led to increased expressions of distress and a threat of personal harm, resulting in the deterioration of the resident's mental and psychosocial well-being. An example of severity level 3 noncompliance. Actual harm that is not immediate jeopardy includes, but is not limited to, facility staff failed to intervene when a visibly agitated and confused resident was pacing the hallways. Record review showed that these expressions of distress had occurred during the late afternoon and early evening for the past 3 weeks. A CNA told the surveyor that the DON said the resident had sundowning. However, when asked, she was unable to explain what that meant or what individualized interventions should be implemented. She was told to leave the resident alone and let him tire himself out. The facility lacked competent staff with the knowledge and skills sets to support and assist the resident who was experiencing agitation and confusion on a daily basis. This resulted in increased distress over the course of several weeks without the development and implementation of individualized, non-pharmacological approaches to care. An example of severity level 2 noncompliance. No actual harm with likelihood for more than minimal harm that is not immediate jeopardy includes, but is not limited to. The facility failed to have sufficient numbers of staff who had the skills and competencies to monitor a resident with SUD and who had just returned from a leave of absence LOA. The resident had a history of substance abuse when on LOA and had care plan interventions indicating to monitor every 15 minutes for signs and symptoms of substance use, which included changes in behavior, slowed respirations, and somnolence. Upon interview of the nurse's aide assigned to monitor this resident, the aide did not know what somnolence was and could not state what a normal respiratory rate was. The aide also stated that he or she had never been assigned to this resident before and was unaware of what the resident's baseline behaviors were. Therefore, the aide could not state if he or she had observed any changes in the resident's behaviors. This was the only aide working the unit when the resident returned from LOA. A surveyor heard a resident complaining to nursing home staff that he was late for his meeting again. The resident told the surveyor that he has missed his weekly Alcoholics Anonymous meeting held at the local church for the last 3 weeks and that this made him angry. Record review showed that attendance at these meetings was a part of his care plan. During an interview, a CNA who helps the resident with his activities of daily living on a consistent basis stated that she was busy and did her best to make sure he was ready when his transportation arrived. The facility failed to implement the resident's care planned interventions, causing him to consistently miss his AA meetings. This led to feelings of anger and had the potential to jeopardize the resident's sobriety. Severity level 1. No actual harm with likelihood for minimal harm. Severity level 1 does not apply for this regulatory requirement because any facility practice that results in a reduction of psychosocial well-being diminishes the resident's quality of life, because more than minimal harm is likely. Any deficiency for this requirement is at least a severity level 2. For additional guidance, see also the Psychosocial Outcome Severity Guide, the CMS Nursing Homes Survey Resources website that can be accessed by visiting https://www.cms.gov/files/zip/survey resources 10,262,022 zip. References to non-CMS sources are provided as a service. and do not constitute or imply endorsement of these organizations or their programs by CMS or the U.S. Department of Health and Human Services. CMS is not responsible for the content of pages found at these sites. URL addresses were current as of the date of this publication. Tag F742. Section 483.40b. Based on the comprehensive assessment of a resident, the facility must ensure that Section 483.40b1. A resident who displays or is diagnosed with mental disorder or psychosocial adjustment difficulty, or who has a history of trauma and or post-traumatic stress disorder, receives appropriate treatment and services to correct the assessed problem or to attain the highest practicable mental and psychosocial well-being. Definitions: Section 483.40b and Section 483.40b1. Definitions are provided to clarify terminology related to behavioral health services and the attainment or maintenance of a resident's highest practicable well-being. Mental disorder and psychosocial adjustment difficulty refers to the development of emotional and or behavioral symptoms in response to an identifiable stressor that has not been the resident's typical response to stressors in the past, or an inability to adjust to stressors as evidenced by chronic emotional and or behavioral symptoms. Adapted from Diagnostic and Statistical Manual of Mental Disorders 5th edition, 2013. American Psychiatric Association. Intent: Section 483.40b and Section 483.40b1. The intent of this regulation is to ensure that a resident who, upon admission, was assessed and displayed, or was diagnosed with a mental or psychosocial adjustment difficulty or a history of trauma and or post-traumatic stress disorder PTSD, receives the appropriate treatment and services to correct the initial assessed problem or to attain the highest practicable mental and psychosocial well-being. Residents who were admitted to the nursing home with a mental or psychosocial adjustment difficulty, or who have a history of trauma and or PTSD, must receive appropriate person-centered and individualized treatment and services to meet their assessed needs. Guidance: Section 483.40b and Section 483.40b1. Residents who experience mental or psychosocial adjustment difficulty, or who have a history of trauma and or post-traumatic stress disorder PTSD, require specialized care and services to meet their individual needs. The facility must ensure that an interdisciplinary team which includes the resident's family and or representative, whenever possible, develops and implements approaches to care that are both clinically appropriate and person-centered. Expressions or indications of distress, lack of improvement, or decline in resident functioning should be documented in the resident's record and steps taken to determine the underlying cause of the negative outcome. For additional information regarding non-pharmacological interventions, see Section 483.40a2, F741, Implementing Non-Pharmacological Interventions. What is appropriate treatment and services to correct the assessed problem or to attain the highest practicable mental and psychosocial well-being? The facility must provide the appropriate treatment and services to correct the assessed problem or to attain the highest practicable mental and psychosocial well-being. The determination of what is appropriate is person-centered and would be based on the individualized assessment and comprehensive care plan. To the extent that the care plan identifies particular treatment and services, the facility must make reasonable attempts to provide these services directly or assist residents with accessing such services. A facility must determine through its facility assessment what types of behavioral health services it may be able to provide. Some examples of treatment and services for psychosocial adjustment difficulties may include providing residents with opportunities for autonomy, arrangements to keep residents in touch with their communities, cultural heritage, former lifestyle and religious practices, and maintaining contact with friends and family. The coping skills of a person with a history of trauma or PTSD will vary, so assessment of symptoms and implementation of care strategies should be highly individualized. Facilities should use evidence-based interventions, if possible. Background on trauma and PTSD. A close relationship exists between mental and psychosocial adjustment difficulties. Histories of trauma and PTSD. Adjustment difficulties occur within 3 months of the onset of a stressor and last no longer than 6 months after the stressor or its consequences have ended. Are characterized by distress that is out of proportion to the severity or intensity of the stressor, taking into account external context and cultural factors and / or a significant impairment in social, occupational, or other important areas of functioning. May be related to a single event or involve multiple stressors and may be recurrent or continuous. May cause a depressed mood, anxiety, and / or aggression. May be diagnosed following the death of a loved one when the intensity, quality, or persistence of grief exceeds what normally might be expected, and can occur for individuals with or without PTSD or a history of trauma. History of trauma. Involves psychological distress following a traumatic or stressful event that is often variable. May be connected to feelings of anxiety and / or fear. Often involves expressions of anger or aggressiveness, and some individuals who experience trauma will develop PTSD. PTSD. Involves the development of symptoms following exposure to one or more traumatic, life-threatening events. Usually develops within the first 3 months after the trauma occurs, although there may be a delay in months or even years. Symptoms may include, but are not limited to, the re-experiencing or reliving of the stressful event, e.g., flashbacks or disturbing dreams, emotional and behavioral expressions of distress, e.g., outbursts of anger, irritability, or hostility, extreme discontentment or inability to experience pleasure, as well as dissociation, e.g., detachment from reality, avoidance, or social withdrawal, hyperarousal, e.g., increased startle response or difficulty sleeping, and may be severe or long-lasting when the stressor is interpersonal and intentional, e.g., torture or sexual violence. Adapted from American Psychiatric Association, Diagnostic and Statistical Manual of Mental Disorders, 5th edition, Arlington, VA, American Psychiatric Association. Publishing, 2013. Although PTSD is commonly viewed as a disorder experienced only by military veterans, it is not exclusively a consequence of combat or war zone exposure. Individuals who have been physically or sexually assaulted, or who experienced a terrorist attack or natural disaster, among other things, may also be affected by PTSD. Additionally, some older nursing home residents may have lived through a time of genocide and witnessed or been subjected to the intentional and systematic destruction of a racial, political, or cultural group such as that which occurred during the Holocaust in World War II. Moving from the community into a long-term care facility for an individual with a history of trauma or PTSD can be a very difficult transition and cause worsening or Reemergence of symptoms. Additionally, the structured environment of the nursing home can trigger memories of traumatic events, and coping with these memories may be more difficult for older adults. Key elements of noncompliance Section 483.40b and Section 483.40b1. To cite deficient practice at F742, the surveyor's investigation will generally show that the facility failed to assess the resident's expressions or indications of distress to determine if services were needed, provide services and individualized care approaches that address the assessed needs of the resident and are within the scope of the resources in the facility. Assessment. Develop an individualized care plan that addresses the assessed emotional and psychosocial needs of the resident. Assure that staff consistently implement the care approaches delineated in the care plan. Monitor and provide ongoing assessment as to whether the care approaches are meeting the emotional and psychosocial needs of the resident, or review and revise care plans that have not been effective and or when the resident has a change in condition, and accurately document all of these actions in the resident's medical record. Note, for behavioral health care concerns that do not pertain to residents who display or are diagnosed with a mental disorder or psychosocial adjustment difficulty, or who have a history of trauma and or post-traumatic stress disorder, review regulatory requirements at Section 483.40 F740, Behavioral Health Services. Investigative Protocol Section 483.40b and Section 483.40b1. Objectives. The objectives of this protocol are to determine, based on the comprehensive assessment of a resident, that the facility ensured that the resident who displays or is diagnosed with a mental or psychosocial adjustment difficulty, or who has a history of trauma and or PTSD, receives the care and services necessary to reach and maintain the highest level of mental and psychosocial functioning. Procedures. In order to guide observations, briefly review the comprehensive assessment and interdisciplinary care plan. Observations. Observe for manifestations related to mental and psychosocial adjustment difficulties. A. History of trauma and or PTSD, which may, over a period of time, include impaired verbal communication without physiological cause, social isolation and withdrawal inconsistent with the resident's usual demeanor, sleep pattern disturbance, e.g., disruptive change in sleep/rest pattern as related to one's biological and emotional needs, deviation from past spiritual beliefs or rituals, alterations in one's belief system, inability to control behavior, anger, and the potential for physical harm to oneself or others, and stereotyped response to any stressor, i.e., the same characteristic response, regardless of the stimulus. Note, observe staff interactions with the resident in formal and informal situations, and determine whether or not they implement interventions in accordance with the care plan. Interviews. Resident/resident representative. Interview the resident, resident's family, or representative to the degree possible. 2. Determine awareness of the current condition or history of the condition or diagnosis/diagnoses. Participation in the development of a person-centered care plan. Whether or not resident choices and preferences are considered, and validity of observations and data collection. Staff interviews. Interview IDT member as necessary to determine whether or not care provided is consistent with the care plan, and that staff are knowledgeable about how to support the resident when they are expressing or indicating feelings of distress, Additionally, speaking to staff on various shifts can help to determine staff knowledge of facility-specific guidelines and protocols related to the treatment of mental disorders and psychosocial adjustment difficulties, history of trauma and PTSD. Whether certified nurse aides, CNA know how, what, when, and to whom to report changes in condition. How facility staff monitor care plan implementation and changes in condition. And how changes in both the care plan and the resident's condition are communicated to the staff. Record review. Identify if the resident triggers care area assessments CAW for activities, mood, state, psychosocial well-being, and psychotropic drug use. O. Consider whether the CAA process was used to assess the causal factors for decline, potential for decline or lack of improvement. Review the resident's care plan for interventions to address the assessed problem. How are mental and psychosocial adjustment difficulties, a history of trauma, and or PTSD addressed in the care plan? O. Does it describe the expressions or indications of distress that the resident has experienced because of the assessed problem? O. Does it describe the programs and activities that have been implemented to assist the resident in reaching and maintaining the highest level of mental and psychosocial functioning? O. Is the care plan written in measurable language that allows assessment of its effectiveness? Are the data to be collected to evaluate the effectiveness of the care plan identified? Are the data collection done according to the care plan? Is there an assessment of the resident's usual and customary routines and preferences? O. Are accommodations made by the facility to support the resident by incorporating these routines and preferences in the care plan? Does record review indicate that the care and services outlined in the care plan are effective in decreasing the resident's expressions or indications of distress? If the data collected indicate that expressions or indications of distress are unchanged in frequency or severity over 2 or more assessment periods, is the plan reassessed and intervention approaches revised to support the resident attaining the highest practicable mental and psychosocial well-being? Note, clinical conditions that may produce apathy, malaise, and decreased energy levels that can be mistaken for depression associated with mental or psychosocial adjustment difficulty may include, but are not limited to, metabolic or endocrine disorders, e.g., Cushing's disease, diabetes/hypoglycemia, hypothyroidism, central nervous system disorders, e.g., tumors and other mass lesions, Parkinson's disease, multiple sclerosis, Alzheimer's disease, miscellaneous conditions, e.g., pernicious anemia, pancreatic disease, malignancy, infections, congestive heart failure, hypotension, dehydration, circadian rhythm disruption, overmedication for treatment of other conditions, and use of restraints. Deficiency categorization section 483.40b and section 483.40b1. An example of severity level 4 noncompliance, immediate jeopardy to resident health or safety includes, but is not limited to, a surveyor observed a resident who was crying and exhibiting signs of distress, lying in bed in her room. During an interview, the resident told the surveyor that she had lost all hope, felt betrayed by her family and her faith, and was ready to die. The resident shared that her children sold her house before she came to the nursing home, but that she had planned to go back there to live once her health improved. The resident added that she had lived in that house for 55 years, raising her children and enjoying life. Record review showed that upon admission, the resident indicated her goal was to return home, but also that her house had been sold by her family. Facility progress notes documented increased anxiety and depressive mood, as well as isolation from activities she had previously enjoyed, including attendance at religious services. Additionally, the resident had stopped eating or drinking. She was receiving Roman IV fluids, and the insertion of a feeding tube was being considered. An interview with the care plan coordinator confirmed that the facility failed to develop an individualized care plan that addressed the assessed emotional and psychosocial needs of the resident. During an interview with the social worker, she indicated that she had been aware the house sold, but did not realize the resident was so distraught about it. The facility failed to acknowledge and assess the underlying causes of the residents' expressions of distress or develop and implement a care plan that addressed this distress. This resulted in the deterioration of the residents' physical, mental, and psychosocial well-being. An example of severity level 3 noncompliance actual harm that is not immediate jeopardy includes, but is not limited to, the facility determined that a resident's resistance to receiving staff assistance in the shower was a result of a traumatic event that occurred at home years ago when a home health aide left her in the shower unattended and she fell, fracturing her hip. The resident has never been able to return home since the event and is distrustful of the nursing home staff. Interventions listed on the care plan specified that she is to be assisted by 2 staff members in the shower. The resident is to be approached in an unhurried manner, with calm voices and soft lighting. The surveyor observed the resident in the shower, with only 1 certified nurse aide CNA in attendance and harsh lighting. During the shower, the resident demonstrated anxiety and fear. She was yelling, crying, restless, and tried to get out of the shower chair many times during care. When observed 30 minutes after her shower, the resident was no longer yelling, however she still appeared fearful, and her crying was just beginning to resolve. An interview with the CNA and director of nursing confirmed that the care plan interventions had not been followed. The facility failed to ensure that a resident who has a history of trauma received the appropriate treatment and services to reduce her anxiety and fear in the shower. Care planned interventions were not implemented, leading to increased expressions of distress by the resident and a decline in her mental and psychosocial well-being. An example of severity level 2 noncompliance: no actual harm with likelihood for more than minimal harm that is not immediate jeopardy includes, but is not limited to. A surveyor heard a resident yelling for help. Facility staff and the surveyor followed the sound to the resident's room, where they found her lying in bed in a darkened room, clinging tightly to her wallet and blanket. The staff turned on the lights to assist in calming her down. During an interview later that day, the resident shared that she had been robbed at knife point in her own home prior to being admitted to the nursing home last year. She also mentioned that, although she felt secure in the nursing home, she still had nightmares sometimes, and the nurses are supposed to leave her bathroom light on at night. The resident also asked to be moved to a room closer to the nursing station, but that had not happened yet. Record review of the resident's assessment and care plan documented that the resident did have care planned interventions regarding her increased need for reassurance due to the robbery prior to admission. Interventions included leaving the resident's bathroom light on at night. Interviews with facility staff confirmed that they sometimes forget to leave the bathroom light on at night for the resident. Additionally, the social worker confirmed that the possibility of a room closer to the nursing station had not yet been investigated. The facility failed to implement person-centered, non-pharmacological approaches to care for a resident with a history of trauma causing the resident increased distress and fear. Severity Level 1. No actual harm with likelihood for minimal harm. Severity Level 1 does not apply for this regulatory requirement because any facility practice that results in a reduction of psychosocial well-being diminishes the resident's quality of life, because more than minimal harm is likely. Any deficiency for this requirement is at least a Severity Level 2. For additional guidance, see also the Psychosocial Outcome Severity Guide at the CMS Nursing Homes Survey Resources website that can be accessed by visiting https://www.cms.gov/files/zip/survey resources. 10,262,022. Zip. Tag F743. Section 483.40B2. A resident whose assessment did not reveal, or who does not have a diagnosis of a mental or psychosocial adjustment difficulty, or a documented history of trauma and or post-traumatic stress disorder, does not display a pattern of decreased social interaction and or increased withdrawn, angry, or depressive behaviors, unless the resident's clinical condition demonstrates that development of such a pattern was unavoidable, and Intent Section 483.40B2. The intent of this regulation is to ensure that a resident who, upon admission, was not assessed or diagnosed with a mental or psychosocial adjustment difficulty, or a documented history of trauma and or post-traumatic stress disorder (PTSD), does not develop patterns of decreased social interaction and or increased withdrawn, angry, or depressive behaviors while residing in the facility. However, after admission, if the resident is diagnosed with a condition that typically manifests a similar pattern of behaviors, documentation must validate why the pattern was unavoidable, e.g., symptoms did not initially manifest, family was unaware of previous trauma, or were unavailable for interview, etc. Development of an unavoidable pattern of behaviors refers to a situation where the interdisciplinary team, including the resident, their family, and or resident representative, has completed comprehensive assessments, developed and implemented individualized, person-centered approaches to care through the care planning process, revised care plans accordingly, and behavioral patterns still manifest. Guidance Section 483.40B2. Nursing home admission can be a stressful experience for a resident, his or her family, and or representative. Behavioral health is an integral part of a resident's assessment process and care plan development. The assessment and care plan should include goals that are person-centered and individualized to reflect and maximize the resident's dignity, autonomy, privacy, socialization, independence, choice, and safety. Facility staff must monitor the resident closely for expressions or indications of distress, assess and plan care for concerns identified in the resident's assessment, accurately document the changes, including the frequency of occurrence and potential triggers, in the resident's record, share concerns with the interdisciplinary team IT to determine underlying causes, including differential diagnosis, ensure appropriate follow-up assessment if needed, and discuss potential modifications to the care plan. For additional information regarding non-pharmacological interventions, see Section 483.40A2, F741, Implementing Non-Pharmacological Interventions. Key elements of noncompliance Section 483.40B2. To cite deficient practice at F743, the surveyor's investigation will generally show the facility failed to identify that a resident developed decreased social interaction and or increased withdrawn, angry, or depressive behaviors, and may have made verbalizations indicating these Evaluate whether the resident's distress was attributable to their clinical condition, and demonstrate that the change in behavior was unavoidable. Ensure an accurate diagnosis of a mental disorder or psychosocial adjustment. Difficulty or PTSD was made by a qualified professional. Adequately assess and or develop care plans for services and individualized care. Approaches that support the needs of residents who develop these patterns. Provide services with an individualized care approach that support the needs of residents with these indicators. Provide staff with training opportunities related to the person-centered care. Approaches that have been developed and implemented. Assure that staff consistently implement the approaches delineated in the care plan. Monitor and provide ongoing assessment as to whether the care approaches are meeting the needs of the resident, or review and revise care planned interventions and accurately document the reason for revision in the resident's medical record. Investigative Protocol Section 483.40b2. Objectives. The objective of this protocol is to determine whether or not the facility meets the regulatory requirements for a resident who has displayed a pattern of decreased social interaction and or increased withdrawn, angry, or depressive expressions or indications of distress. Procedures. Briefly review the comprehensive assessment and interdisciplinary care. Plan to guide observations. Observations. Observe residents who appear to be isolated, withdrawn, angry, or have other expressions or indications of mental or psychosocial difficulties, a history of trauma, and or PTSD. Additionally, observations may include, but are not limited to, staff and resident interactions. Demonstration of the staff's understanding, responsiveness, and proactive care for residents' needs, and implementation of care plan interventions by staff. Interviews. Resident/resident representative. Interview the resident, resident's family, or representative to the degree possible to determine the level of social interaction and distress that was present upon admission, whether social interaction has diminished or increased since admission, if withdrawal, anger, and depressive expressions or indications of distress have increased without a change in the resident's clinical condition. Participation in the development of a person-centered care plan, and whether or not resident choices and preferences are considered. Staff interviews. In the case where staff members have noted changes in a resident's social interactions and behaviors after admission to the facility, and the care plan does not reflect these changes, the surveyor must interview IDT member as necessary to determine whether or not facility staff are aware of changes in the resident's social interactions and or behavior, that staff are knowledgeable about how to support the resident when they are expressing or indicating feelings of distress, whether or not facility staff, including the resident, their family, and or resident representative have reviewed the resident's care plan and revised it as necessary to reflect the resident's current needs and goals. Additionally, speaking to staff on various shifts can help to determine their knowledge of facility-specific guidelines and protocols related to the treatment of mental disorders and psychosocial adjustment difficulties, history of trauma and PTSD. Whether certified nurse aides know how, what, when, and to whom to report changes in condition, including changes in a resident's social interactions and behaviors, e.g., residents who have begun to withdraw, express anger, and or depression. How facility staff monitor the implementation of the care plan and respond to changes in the resident's social interactions and behaviors, and how changes in both the care plan and the resident's condition are communicated. To the staff. Record review. Determine whether or not upon admission the resident had a diagnosis of or displayed a mental or psychosocial adjustment difficulty or a documented history of trauma or PTSD. Review the resident's medical record for documentation related to a pattern of decreased social interaction and or increased withdrawn, angry, or depressive expressions or indications of distress. Review nursing, social service, mental health notes, or other discipline notes for description of the distress. Review the resident assessment instrument, RI, and identify if the minimum data set MDS captures and was used to assess the resident's conditions. Look to see that the resident care area assessments CAW for activities, mood state, psychosocial well-being, and psychotropic drug use trigger for any reason in the absence of related diagnoses or difficulties, or history of trauma and or PTSD. Consider whether the CAA process was used to identify and assess the reason and causal factors for decline, potential for decline, or lack of improvement. Is there an assessment of the resident's usual and customary routines and preferences? O are accommodations made by the facility to support the resident by incorporating these routines and preferences in the care plan. Review the resident's care plan to determine if interventions are in place to alleviate the assessed distress. O, does it thoroughly describe the distress from a person-centered perspective? O, does it describe the programs and activities that have been implemented to assist the resident in reaching and maintaining the highest level of mental and psychosocial functioning? O is the care plan written in measurable language that allows assessment of its effectiveness. O, does the record review indicate that the care and services outlined in the care plan are effective? Deficiency Categorization Section 483.40b2. An example of severity level 4 noncompliance. Immediate jeopardy to resident health or safety includes, but is not limited to, the facility failed to identify signs of distress exhibited by a resident who, according to the medical record, for the past month had begun rising from bed mid-morning and returning to bed immediately after dinner. This was a departure from her previous morning and night sleep patterns. Upon interview, staff communicated that as people age, they grow tired more easily and require more sleep. The staff also noted that the resident was often very tearful and seemed depressed, but again they felt that this was normal for older adults, even though she experienced a significant weight loss and did not want to speak to a social worker when approached about these noted changes. The staff honored her wish to be left in bed. During the resident interview, she stated that she was tired and just wanted to sleep. She informed the surveyor that the last of her friends had just died, leaving her with no other childhood contacts or meaningful social relationships other than her family. She began crying and stated that she often cried but tried not to in front of the staff because she was too proud. She felt that by sleeping a lot, she wouldn't have to face the fact that she also would die soon. The facility's failure to identify that the resident was in distress and needed a mental health assessment caused a delay in receiving appropriate services and a deterioration in the resident's psychosocial well-being. An example of severity level 3, actual harm that is not immediate jeopardy, includes, but is not limited to. During the tour of the facility, the surveyor noticed a resident sitting by the front door of the facility, wringing his hands and staring out the window. While engaged in conversation, he stated that he was afraid that he would miss his group again. He had to come to the nursing home after his wife's death and was having a hard time adjusting to the change. He stated that he joined a grief support group that he was finding helpful but had not been able to attend for a few weeks. He was unable to sleep at night because of the worry about missing the group sessions. His care plan indicated that the only intervention to address his grief was participation in a weekly support group meeting at the senior center. His goal was to attend group sessions so he could better cope with the multiple losses he had experienced. An interview with the facility administrator revealed that the resident had been unable to attend group sessions for 6 weeks because the facility's only van was in the shop. During those weeks, the facility failed to provide alternative interventions and address the distress caused by the missed meetings. The resident's medical record reflected that in the past month he appeared more anxious, depressed, and angry, and staff described him as not his pleasant self. The resident suffered a decline as a direct result of being unable to attend his weekly support group meetings, and the facility did not seek any alternatives when transportation was unavailable. An example of severity level 2, no actual harm with likelihood for more than minimal harm that is not immediate jeopardy includes, but is not limited to. After falling at home and fracturing her femur, a resident was admitted to the skilled nursing facility for rehabilitation services. She had no history of mental or psychosocial adjustment difficulty, trauma other than the fall, and or PTSD. When she was first admitted, she was very involved in facility events and activities and participated enthusiastically in therapy. During observation of the breakfast meal, the surveyor noticed that the resident appears quite tired and asked the physical therapist if therapy could be postponed until later in the afternoon so she could go back to bed. When questioned, the resident stated that she has not had a good night's sleep since admission due to the woman in the next room yelling most of the night. The resident also stated that she does not want to complain since she knows that the woman yelling has dementia. However, it is getting harder for her to get enough rest, and she finds herself feeling irritable and depressed from her lack of sleep. The physical therapist reported that the resident has not been progressing as well as she was when she was first admitted, and when she attends therapy, she tires and becomes frustrated easily. The resident's lack of rest and feeling of sadness stemmed from the staff's inability to realize that the distress of another resident was affecting other residents. The resident's sleep pattern had already been disrupted for several nights, and she was too tired to participate in therapy. If the situation continues, it could lead to a decline in the resident's clinical condition. Severity level 1, no actual harm with likelihood for minimal harm. Severity level 1 does not apply for this regulatory requirement because any facility practice that results in a reduction of psychosocial well-being diminishes the resident's quality of life. Because more than minimal harm is likely, any deficiency for this requirement is at least a severity level 2. For additional guidance, see also the Psychosocial Outcome Severity Guide at the CMS Nursing Homes Survey Resources website that can be accessed by visiting https://www.cms.gov/files/zip/survey resources. 10,262,022, zip. Tag F744. Section 483.4, 0B3. A resident who displays or is diagnosed with dementia receives the appropriate treatment and services to attain or maintain his or her highest practicable physical, mental, and psychosocial well-being. Definitions, Section 483.4, 0B3. Definitions are provided to clarify terminology related to dementia and the attainment or maintenance of a resident's highest practicable well-being. Dementia is a general term to describe a group of symptoms related to loss of memory, judgment, language, complex motor skills, and other intellectual function. Caused by the permanent damage or death of the brain's nerve cells or neurons. However, dementia is not a specific disease. There are many types and causes of dementia with varying symptomology and rates of progression, adapted from About Dementia. Alzheimer's Foundation of America, 30. NOV 2016. Accessed at https://www.altsofdenorg/about-dementia/definition.html. Highest practicable physical, mental, and psychosocial well-being is defined as the highest possible level of functioning and well-being, limited by the individual's recognized pathology and normal aging process. Highest practicable is determined through the comprehensive resident assessment and by recognizing and competently and thoroughly addressing the physical, mental, or psychosocial needs of the individual. Guidance Section 483.40b3. Providing care for residents living with dementia is an integral part of the person-centered environment, which is necessary to support a high quality of life with meaningful relationships and engagement, fundamental principles of care for persons living with dementia involve an interdisciplinary approach that focuses holistically on the needs of the resident living with dementia, as well as the needs of the other residents in the nursing home. Additionally, it includes qualified staff that demonstrate the competencies and skills to support residents through the implementation of individualized approaches to care, including direct care and activities that are directed toward understanding, preventing, relieving, and/or accommodating a resident's distress or loss of abilities. If there are staffing concerns related to the provision of behavioral health services, refer to Section 483.40a F741, sufficient and competent staff. The facility must provide dementia treatment and services which may include, but are not limited to, the following: ensuring adequate medical care, diagnosis, and supports based on diagnosis. Ensuring that the necessary care and services are person-centered and reflect the resident's goals, while maximizing the resident's dignity, autonomy, privacy, socialization, independence, choice, and safety, and utilizing individualized, non-pharmacological approaches to care, e.g., purposeful and meaningful activities. Meaningful activities are those that address the resident's customary routines, interests, preferences, and choices to enhance the resident's well-being. It is expected that a facility's approach to care for a resident living with dementia follows a systematic care process in order to ensure that residents' individualized dementia care needs are met. The facility is expected to assess, develop, and implement care plans through an interdisciplinary team-IT approach that includes the resident, their family, and/or resident representative to the extent possible. Care plan goals must be achievable, and the facility must provide those resources necessary for an individual resident to be successful in reaching those goals. Surveyors must determine whether the failure to attain or maintain the highest practicable physical, mental, and psychosocial well-being in accordance with the comprehensive assessment and care plan was avoidable or unavoidable. An unavoidable facility failure refers to a situation where the IDT has completed comprehensive assessments, developed and implemented individualized, person-centered approaches to care through the care planning process, revised care plans accordingly, and residents are unable to attain or maintain their highest practicable physical, mental, and psychosocial well-being. Residents living with dementia require specialized services and supports, e.g., specialized activities, nutrition, and environmental modifications that vary based on the individuals' abilities and challenges related to their condition. Dementia causes significant intellectual functioning impairments that interfere with life, including activities and relationships. People living with dementia may lose their ability to communicate, solve problems, and cope with stressors. They may also experience fear, confusion, sadness, and agitation. While memory loss is a common indication of dementia, memory loss by itself does not mean that a person has dementia. Although it is common in very elderly individuals, dementia is not a normal part of the aging process. There are several diseases that can cause symptoms of dementia, e.g. Alzheimer's disease, vascular dementia, Lewy body dementia. Other conditions can also cause dementia or dementia-like symptoms including, e.g., reactions to medications, metabolic problems and endocrine abnormalities, nutritional deficiencies, and heart and lung problems. Some individuals living with dementia may have coexisting symptoms, such as paranoia, delusions or hallucinations, or psychiatric conditions, such as depression or bipolar affective disorder. Progressive dementia may exacerbate these symptoms and conditions. Behavioral or psychological expressions are occasionally related to the brain disease in dementia. However, they may also be caused or exacerbated by environmental triggers. Such expressions or indications of distress often represent a person's attempt to communicate an unmet need, discomfort, or thoughts that they can no longer articulate. Medications may be unnecessary and are likely to cause harm when given without a clinical indication, at too high of a dose, for too long after the resident's distress has been resolved, or if the medications are not monitored. However, medications may be effective when the underlying cause of a resident's distress has been determined and non-pharmacologic approaches to care have been ineffective, or for expressions of distress that have worsened. All approaches to care, non-pharmacological and pharmacological, need to be person-centered, monitored for efficacy, risks, benefits, and harm, and revised as necessary. If there are concerns about medication use in dementia, refer to Section 483.4, 5D F757. Unnecessary drugs and Section 483.4, 5EF 758, psychotropic drugs. Key elements of noncompliance Section 483.4, 0B3. To cite deficient practice at F744, the surveyor's investigation will generally show that the facility failed to assess resident treatment and service needs through the resident assessment instrument RI process, identify, address, and / or obtain necessary services for the dementia care needs of residents, develop and implement person-centered care plans that include and support the dementia care needs identified in the comprehensive assessment, develop individualized interventions related to the resident's symptomology and rate of progression, e.g., providing verbal, behavioral, or environmental prompts to assist a resident with dementia in the completion of specific tasks, review and revise care plans that have not been effective and / or when the resident has a change in condition, modify the environment to accommodate resident care needs, or achieve expected improvements or maintain the expected stable rate of decline. Investigating concerns related to dementia care treatment and services. Use the Dementia Care Critical Element Pathway CMS 20133, along with guidance, when determining if the facility meets the requirements pertaining to the treatment and services for a resident who displays or is diagnosed with dementia. Treatment and services must meet the resident's highest practicable physical, mental, and psychosocial well-being. Review, as needed, all appropriate resident assessments, associated care planning and care plan revisions, along with physician's orders to identify initial concerns and guide. The investigation. Review the minimum data set MDS and other supporting documentation to help determine if the facility is in compliance. Observe for evidence that dementia care needs are met and related services are provided. Staff are expected to assess and provide appropriate care for residents with dementia. Interview the resident, their family, and/or representatives and the IDT as needed to gather information about dementia care in the nursing home. Corroborate the information obtained and any concerns noted during the survey by building upon the investigation through additional observations, interviews, and record review. In determining compliance, additionally, refer to the Psychosocial Severity Outcome Guide at the CMS Nursing Homes Survey Resources website that can be accessed by visiting https://www.cms.gov/files/zip/survey. Resources 10,262,022, zip. Deficiency Categorization Section 483.40b3. An example of Severity Level 4, immediate jeopardy to resident health or safety, includes, but is not limited to, based upon a comprehensive assessment by a qualified professional, it was identified that a resident living with dementia required close supervision to prevent injury. The resident's care plan indicated that the facility had developed individualized interventions to support him. However, documentation in the resident's record provided information about an incident that had occurred recently as a result of lack of supervision. When left alone in the bathroom, the resident sustained second-degree burns to his hand from hot water, requiring treatment at the emergency room. Following the incident, no revisions were made to the resident's care plan. The facility failed to implement individualized interventions, as well as revise the care plan accordingly to address the resident's dementia care needs, resulting in injury as evidenced by observation, record review, and/or interview. An example of Severity Level 3, actual harm that is not immediate jeopardy, includes, but is not limited to, the care plan for a resident with an identified diagnosis of dementia included the need for close supervision to prevent the resident from wandering into the rooms of other residents. However, the review of the care plan indicated that the facility had failed to develop person-centered interventions to prevent the resident from wandering. The record review also provided information about a resident altercation that had occurred a week prior to the survey. The altercation involved a sweater that was removed from the room of another resident, who slapped and scratched the resident living with dementia because she refused to return the garment. The resident received minor lacerations and bruising, which was cared for by the direct care staff at the nursing home. The care plan was revised to reflect the need to closely supervise. During the survey, the resident was observed wandering in and out of resident rooms. When questioned, direct care staff were unaware that the resident required close supervision. The facility failed to develop and implement interventions to address the resident's dementia care needs, resulting in the resident's inability to achieve her highest level of functioning. An example of Severity Level 2, no actual harm with likelihood for more than minimal harm that is not immediate jeopardy. A resident was observed standing in her doorway, asking what day of the week it was. 2 staff members were within hearing distance, but did not reply to the resident. The surveyor also noticed that there was no calendar in the resident's room. Review of the resident's record showed that she had a diagnosis of dementia. The care plan noted that the resident has a tendency to forget what day of the week it is, and can become anxious when not reminded. Interventions include that staff are to ensure that a current calendar is on her bedroom wall and remind the resident what day it is when she wakes up each morning and when facility staff are asked. The facility failed to support the resident and implement planned interventions to reduce her confusion, which had the potential to cause the resident anxiety. Severity Level 1. No actual harm with likelihood for minimal harm. Severity Level 1 does not apply for this regulatory requirement because any facility practice that results in a reduction of psychosocial well-being diminishes the resident's quality of life, because more than minimal harm is likely. Any deficiency for this requirement is at least a severity level 2. For additional guidance, see also the Psychosocial Outcome Severity Guide at the CMS Nursing Homes Survey Resources website that can be accessed by visiting https://www.cms.gov/files/zip/survey resources. 10,262,022 zip. Note, if there are indications that a resident is in a secured/locked area without a clinical justification and / or placement is against the will of the resident, their family, and / or resident representative, review regulatory requirements at Section 483.12 and Section 483.12a. F603, Involuntary Seclusion. End of Tag F744. Tag F745. Section 483.40d. The facility must provide medically related social services to attain or maintain the highest practicable physical, mental, and psychosocial well-being of each resident. Intent Section 483.40d. To assure that sufficient and appropriate social services are provided to meet the residents' needs. Definitions, Section 483.40d. Definitions are provided to clarify terminology related to behavioral health services and the attainment or maintenance of a resident's highest practicable well-being. Medically related social services means services provided by the facility's staff to assist residents in attaining or maintaining their mental and psychosocial health. Guidance Section 483.40d. All facilities are required to provide medically related social services for each resident. Facilities must identify the need for medically related social services and ensure that these services are provided. It is not required that a qualified social worker necessarily provide all of these services, except as required by state law. If there are concerns about requirements involving qualified social workers, refer to Section 483.700 F. 850, Social Worker. Examples of medically related social services include, but are not limited to the following: advocating for residents and assisting them in the assertion of their rights within the facility in accordance with Section 483.10, Resident Rights, Section 483.12, Freedom from abuse, neglect, and exploitation, Section 483.15, Transitions of Care, Section 483.20, Resident Assessments PASAR, and Section 483.21, Comprehensive Person-Centered Care Planning, assisting residents in voicing and obtaining resolution to grievances about treatment, living conditions, visitation rights, and accommodation of needs, assisting or arranging for a resident's communication of needs through the resident's primary method of communication or in a language that the resident understands, making arrangements for obtaining items, such as clothing and personal items, assisting with informing and educating residents, their family, and / or Representative about healthcare options and ramifications. Making referrals and obtaining needed services from outside entities, e.g., talking. Books, absentee ballots, community wheelchair transportation. Assisting residents with financial and legal matters, e.g., applying for pensions. Referrals to lawyers, referrals to funeral homes for pre-planning arrangements. Transitions of care services, e.g., assisting the resident with identifying. Community placement options and completion of the application process. Arranging intake for home care services for residents returning home, assisting. With transfer arrangements to other facilities. Providing or arranging for needed mental and psychosocial counseling services. Identifying and seeking ways to support residents' individual needs through the assessment and care planning process. Encouraging staff to maintain or enhance each resident's dignity in recognition of each resident's individuality. Assisting residents with advanced care planning, including but not limited to completion of advance directives for additional information pertaining to advance directives. Refer to Section 483.10 G12 F578, Advance Directives. Identifying and promoting individualized, non-pharmacological approaches to care that meet the mental and psychosocial needs of each resident, and meeting the needs of residents who are grieving from losses and coping with stressful events. Situations in which the facility should provide social services or obtain needed services from outside entities include, but are not limited to, the following: lack of an effective family or community support system or legal representative, expressions or indications of distress that affect the resident's mental and psychosocial well-being resulting from depression, chronic diseases, e.g., Alzheimer's disease and other dementia-related diseases, schizophrenia, multiple sclerosis, difficulty with personal interaction and socialization skills, and resident-to-resident altercations. Abuse of any kind, e.g., alcohol or other drugs, physical, psychological, sexual. Neglect, exploitation. Difficulty coping with change or loss, e.g., change in living arrangement, change in condition or functional ability, loss of meaningful employment or activities, loss of a loved one, and need for emotional support. Note, when needed services are not covered by Medicaid, nursing facilities are still required to attempt to obtain these services on behalf of the resident, e.g., arranging transportation services. This concludes the reading of Appendix PP. Regulation Section 483.40, tags F740 through F745.